And now I will begin. My talk is on the pathways model. Whoa, this worked a moment ago.
A little temperamental. I think you two pointed maybe a little more towards the right.
Okay. My university, Saybrook University in Pasadena. My take-home messages. Well, first of all, the power of self-care practices. We've been doing them. In our field of biofeedback, we've been sending people to do homework and autogenics and all sorts of everyday practices, self-regulation skills. We've recommended lifestyle changes. Today I'm going to talk about an organized framework to utilize these things. But my take-home message is to reiterate that we do more of what we're already doing. And then the second take-home message is the important role for biofeedback and self-regulation therapies in chronic illness and stress-related medical conditions. The pathways model was actually Angel McGrady's idea. Angel and I have been colleagues. We've participated together as editors and writers in past publications, but in 2013 we brought out Pathways to Illness, Pathways to Health, and then 2018 we brought out Integrated Pathways, Navigating Chronic Illness with a Mind-Body-Spirit Approach. The Pathways principle is to address the continuum of health and disease, the role of health risk behaviors, which produce illness, and the role of well behaviors, which shape higher levels of wellness. We're interested in finding where the individual is on this continuum, identifying current levels of health, but also areas of insufficiency, deficiency, or disease. We were inspired by Dean Ornish's research in lifestyle medicine. Patients with cardiovascular illness in Dean Ornish's studies achieved reductions in triglycerides, blood pressure, increases in myocardial perfusion. Many patients in his lifestyle medicine programs showed a measurable opening of the coronary artery blockages through a reversal of plaque formation. That's remarkable. By changing lifestyle. Following his program, cardiac patients with depressive illness also show significant improvements in depressive mood. We utilized John Travis's illness-wellness continuum, which I hope most of you recognize. He developed it in the 1970s, and he's developed prettier graphics for it more recently. But the importance is that we look at the entire spectrum. I've had an HMO contract in past years in which I was reminded that I was responsible to help the patient reduce their symptoms and return them to their previous level of relative ill health. And my own passion has always been to help people reach higher levels of wellness, even in the presence of terminal or chronic conditions, that we can at least help people to areas of emotional wellness and spiritual wellness at the highest levels. We're interested in personalizing the pathway, a kind of a coaching process, helping human beings facilitate a self-directed program. Now, right now, Angel and I are working on a book for lay people. We haven't found the right publisher yet. I hope we do, because I think it's important to develop something where people may self-direct. But of course, it's also valuable for us as professionals to facilitate self-directed change. We can assist a patient. We can create an alliance between ourselves and that individual, an alliance for health. We can enter a dialogue and help the patient identify needs and goals. Goals at their own level. When someone comes in to me and says, I want to lose 250 pounds. I'm interested in a smaller goal at their level. Matching the level and type of intervention to that person's goals, needs, resources. We undertake a lifestyle-oriented assessment looking at emotional well-being, cognitive well-being, physical activity, nutrition, substance use, sleep patterns, social areas, spiritual practices, illness self-management, how much are they taking an active role in their own health management, and their readiness for change. We utilize self-ratings like this one, rating the quality of your current spiritual practices, supports, and well-being from the lowest level, spiritual despair and emptiness, all the way up to an abundant presence of spiritual practices and supports with a numerical rating from 1 to 5. Whoop. This is a results. You'll see this. If I'm able to get into my second case narrative today, you will see this again because this is on the patient in the second narrative. But this is an example of a graphic showing the 10 areas and how the person rates themselves from emotions to readiness for change. This person rated herself as 0 in illness self-management because she had managed to ignore years and years and years of recommendations for change. We're also interested in the quantified self, also called self-tracking or personal informatics. Wearable technology which can enhance our self-awareness, monitor our activity and our physiology. I've just gravitated from my Fitbit to my Apple Watch, but there are so many devices today which we can draw on. Breath pacers, we've come to take them for granted. I remember when there was only one and it had to be on a laptop, but now there are so many. Digital prompts for behavior change. This is the Prochaska stages of change model, recognizing that a person may be not yet even thinking about change, or they may be thinking and open to information, but not yet able to approach change. Preparation, determination, getting ready, actually doing something, and then importantly, maintenance, because our life is full of relapses. In our framework, Angela and I have organized activity at 3 different levels. And by the way, I hope Angela is there online on Zoom, because I certainly have enjoyed sharing this development of this framework with Angela over the past, oh goodness, probably 14 years. Level 1 in the Pathways model includes self-directed behavior and lifestyle changes such as increased activity, small levels of activity, enhanced sleep, self-guided small nutritional changes. Level 2 includes acquiring skills, adaptive skills, self-regulation skills, utilizing educational resources, written handouts, educational CDs, and community-based supports. There are more and more supports available, resources available for learning skills, digitally, online, apps. Examples of level 2 would be learning mindfulness skills using an educational CD or with the guidance of a community-based class. And level 3 is when we bring the professionals in. After the individual has already discovered that I can do something and it actually has made a difference for me. Then we move to what can a professional do to intervene to also address these problems. Medical care, psychotherapy, biofeedback, neurofeedback, hypnosis, spiritual counseling, therapeutic massage. Some level 1 interventions, almost always, because it's so basic, almost always includes mindful breathing, nutrition and feeding behavior, something as simple as deciding to prepare more of my own meals, sleep and rest, introducing basic sleep hygiene, making some changes. My patient who was actually running a cosmetics business from her bed and complained that she wasn't sleeping well. She also had a dynamite stereo apparently, and a large screen television. Little sleep hygiene was in order. Simple movement, walking short distances, moving with music. Soothing, Angel brought this in. Rocking, humming, singing. I remember working with a very profoundly depressed woman who was embarrassed that she rocked. And we prescribed rocking as self-soothing, as something positive that she could continue doing, but doing it in a self-aware, deliberate way, instead of feeling like it was a symptom. Reading spiritual texts, praying, quiet time. Level 2 interventions, progressive relaxation skills. Beginning a serious exercise program, again, a step above level 1. Stretching, slow walking, increasing the distance, participating in water-based exercise, meditation classes, meditation practices, mindfulness training. And Gel emphasizes the pause. Introducing a moment of awareness, the ability to pause and consider before I act or before I decide. Learning that every time someone asks me to do something, I will say, I need to think about that overnight before I answer you, because I tend to give myself away and not set limits. Whoop. Going back to community-based resources, gentle yoga classes, Tai Chi, Qigong, aquatherapy. I practiced this talk last week with a bunch of Middle Eastern psychologists in Kuwait, Dubai, and other places. 5 a.m. in the morning for me. And they have a movement in yoga now. I don't remember the full Arabic phrase, but they have a movement throughout the Arab world. I was delighted. Level 3 interventions, again, a wide range. Clinical hypnosis, applied psychophysiology, physical therapy, psychotherapy, guided imagery training by a professional, medical management, including pharmacology, but also the complementary therapies and spiritual practices, acupuncture, energy medicine, somatic body work, Feldenkrais, spiritual counseling. Now, case narratives. I'm going to start with multiple sclerosis. I spent 10 years facilitating a self-help group, a support group for multiple sclerosis patients. And it's a terrible illness. Wide variety of symptoms, quite debilitating. Blurred vision, muscle weakness, impaired motor control, a remitting and relapsing pattern with acute exacerbations where a person who was one day chopping wood, the next day can't sit up or stand up. Progressive, often with severe disability, treatments typically only partially effective, and the patients face a confusing and frightening progression of the illness. We know that the basic mechanism of the disorder is that the body attacks the myelin sheath surrounding nerve fibers in the brain and spinal cord. Myelin is an insulator, so basically we have short circuits and poor transmission of nerve signals, and the disability depends on where the myelin sheath degrades. So the symptoms vary depending on, again, the site and the extent of the myelin loss, and then environmental factors can trigger a worsening of symptoms. Over 400,000 people in the US suffer multiple sclerosis, 2.5 million worldwide. Onset typical between 20 and 50 years of age, twice as frequent for women, and that ratio seems to be getting worse. We don't fully understand why. The prevalence is highest in countries farther from the equator, especially Western industrial countries, affluent countries. A couple of possible mechanisms. One of them may be the high-fat, high-carbohydrate, hypercaloric Western diet. If that's the case, we're going to see a worsening in the rest of the world as they adopt McDonald's as their primary food source. Reduced sun exposure and deficiencies in vitamin D may also be a mechanism. We know there's a genetic contribution that is strong. There is one gene locus, the HLA-DR2 gene locus, that's critical, but there are several other gene pathways, so it's a multi-pathway genetic contribution. And there are gene-environment interactions, including vitamin D level, Epstein-Barr virus, and other bacterial and viral infections. Evaluation for diagnosis includes ruling out other conditions, using an fMRI to look at areas of demyelination, although that's tricky because 5% of people who clearly show a pattern from then on will initially show no lesions on their first fMRI. Spinal tap is used to look for abnormalities in the cerebrospinal fluid, especially IgG, elevated IgG antibodies. Largely symptomatic treatment, managing acute exacerbations of the disease. Now, since 1993, there have been a number of what are called disease-modifying agents which have been approved, beginning with interferon beta medications, but unfortunately they're only partially effective, and many patients still face severe, incapacitating periods of exacerbation. 77% of MS patients in one database used complementary therapies, often vitamins, minerals, non-mineral natural products, relaxation and meditation, and special diets. There has been some guidelines developed way back in 2011, but again, I think individual functional nutrition is better to look at what are the deficiencies for this particular person. And now a case narrative, applying the pathways model to a woman with multiple sclerosis, combining interventions at 3 levels. Level 1, self-directed. Level 2, acquiring skills. Level 3, professionally delivered evidence-based treatment. We'll call this woman Rachel, 36-year-old woman diagnosed with MS. She had good health through childhood and into her late 20s, very athletic, active lifestyle until the onset of the illness. Graduated from a liberal arts college, worked in small businesses as a bookkeeper, and joined an accounting firm. Married at 27 and had 3 daughters within 6 years. After the 3rd birth, she began to experience muscle weakness and blurred vision. Her physician, because she just had a birth, attributed it to hormonal fluctuations. When the symptoms left and came back, the physician diagnosed stress and psychogenic illness. She started thinking about it and thought, wait a minute, I've had a number of these periods of blurred vision and muscles when I didn't have much stress. So she didn't buy it. She had a week of severe muscle weakness, unable to climb out of bed, and then she was referred to a neurologist who ran the usual blood work, fMRI, spinal tap. There were visible areas of demyelination and an elevated IgG index. She had the disorder, multiple sclerosis. She was treated with 5 days of intravenous corticosteroids, then 2 weeks of oral corticosteroids. The goal was to moderate the episode and the symptoms, and there was some benefit, some moderation of the visual disturbance and the muscle weakness. She began a long-term interferon beta program. She was told immediately to stop breastfeeding because of the steroids. She began to experience lability of emotion, episodes of crying out of control. Now, what was the cause of this? It could have been interrupting that closeness with the baby, but the disease process also produces emotional dysregulation, and the medications can cause labile emotions. So we've got all sorts of things impacting on this woman. 3 years after the diagnosis and after several severe exacerbations, she was referred for behavioral health evaluation. She said she felt almost no control over intense sadness and outbursts of sobbing. She understood that some of this might have been neurological with the multiple sclerosis or the medications, might have been medical, but she also believed that she needed to work on acceptance for her losses. Initially, she had a Beck depression score in the severe range, Beck anxiety in the severe range. She reported a loss of confidence and competence in her accounting work. She couldn't concentrate, she couldn't always see the numbers. Her physical activity was reduced with very few aerobic activities. Readiness for change. She liked the idea of doing something for herself. She was frustrated with waiting for the physicians to cure her when clearly the medical treatments that are available are less than reliable. She experienced some benefit, but fairly low levels of benefit. So we assessed her at the preparation, determination stage, ready to get started on some change in her life. She set her own goals. She committed to work initially with her sister on weekends and prepare healthy meals to be frozen and served on days when she couldn't cook, when she was too weak or ill. She also set a goal to walk 3 blocks to a library near her home and then 3 blocks back, 2 to 3 times a week with her oldest daughter when she had the muscle strength. We also encouraged her to set the goal to do mindful breathing, relaxed, gentle, diaphragmatic breathing with pursed lips at approximately 6 breaths a minute, and breathing mindfully, wrapping her awareness around the process of breathing, observing and accepting whatever unfolded during her breathing. We did this exercise with her at the beginning of each visit in the clinic. She did well on these goals for 3 weeks, then suffered a severe exacerbation of the MS. At that point, she was glad that she'd started freezing meals because she could provide food for the family and herself on days she couldn't stand up or cook. She continued using the mindful breathing during the exacerbation and felt calmer in spite of the symptoms. She was unable to walk for 2 weeks, but she was motivated enough that she did upper body stretching because she had better motor control in the upper quadrants of her body. And when she recovered strength in the legs, she began walking again and committed to continue these goals longer term, but she felt ready to do something else. Now, she liked the mindful breathing and said, I want more mindfulness. So she began to listen to an educational CD by John Kabat-Zinn and read his book, beautiful book, Wherever You Go, There You Are. And she enrolled in a mindfulness class at a church near her home. I'm so grateful for community resources. I'm aware of that because I've done interventions in other parts of the world where that's just simply not there. And of course, we have communities with fewer of those supports. Second level activity, she elected to add some self-guided biofeedback to her plan. I showed her how to use the Inner Balance device. The Inner Balance software uses a breath pacer from a sensor, which interacts with the cell phone, to guide the subject to breathe at a pace enhancing large, well-organized oscillations in heart rate. The Inner Balance sensor monitors and displays moment-to-moment changes in heart rate. She also wanted something for her muscle fitness and tone. She was suffering spasticity, but also muscle atrophy because of the lack of activity. Because she had intermittent loss of muscle strength, she had given up on much activity. We referred her to a gym that had a personal trainer with a good background in exercise physiology and physical rehabilitation. He was used to working with people with arthritis and other areas affecting the muscles and affecting movement. She also expressed her some spiritual concerns, said she felt bad about being so angry and bitter at God, and she had a growing sense of despair, like, what is my life for anyway? I can't be a mother, I can't do my job. So we introduced her to a rabbi who had experienced painful illness in her own life and tragic losses in her life, and this rabbi was especially sensitive and was working with several individuals with chronic illness. She attended the mindfulness class and reported that she was forming a kind of mindful bubble around herself, that she could see her weakness, she could see her vision blurring, but it was as though some of you were present for Brad Lichtenstein's meditation yesterday. He said, I am breathed. The breathing is there. Well, it was like there is a blurring, and she was watching it. So there was a kind of a bubble that helped her. She felt more distant from the blurred vision and from the muscle weakness. She also embraced her heart rate variability practices and felt that her previous practice of mindful breathing was flowing into and helping her with the heart rate variability. She could now make large, smooth waveforms of heart rate crossing the screen in synchrony with her breathing. She attended twice weekly sessions with her trainer. She was determined. She went in the wheelchair when she couldn't walk in. And her upper body control, fortunately, was more consistent, so she worked her upper body muscles on days she couldn't stand. She said she wasn't doing so well in the spiritual area. She still was feeling guilt, but also feeling a sense of despair. She said she felt an emptiness and a darkness about her life and the progression of the illness. Well, the rabbi invited her into a spiritual conversations group monthly with 6 other women with chronic illness. Now, excuse me, level 3, professional. Well, she was making changes in her nutrition by preparing some meals ahead, and she had followed guidelines she found online from the MS Society, but we referred her at her request to a registered dietitian with training in functional medicine. She underwent extensive laboratory testing and eliminated dairy-based foods, minimized saturated fats, increased foods high in polyphenols, added a probiotic, vitamin D, and DHA. She still was suffering some muscle weakness and severe spasticity, which is typical with MS, spontaneous contractions of the limbs with pain. She saw a physical therapist who prescribed a series of stretching exercises and taught her progressive muscle relaxation, and utilized surface EMG to augment the PMR training, showing her levels of muscle tension and guiding her with the EMG to relax the musculature. She did well with her home use of inner balance, and in the in-office biofeedback, she committed to 5 sessions of in-office HRV biofeedback with the goal of identifying her resonance frequency, the rate of breathing producing the greatest variability. She also now was ready to begin psychotherapy, and again, she wanted something with mindfulness because she was really liking what she was learning of the mindfulness. She already was benefiting both the breath practices, the heart rate variability practices, and what she was learning in her mindfulness classes were a kind of mind-body psychotherapy. She was desensitizing some of her specific worries and fears, feeling less overwhelmed by them, but she was ready for specific psychotherapy, and she chose acceptance and commitment therapy because of the mindfulness element. For those of you who might not know ACT, instead of disputing or combating distressing thoughts and feelings, ACT guides the person to mindfully observe and accept distressing thoughts and feelings. When she followed her dietary regimen from functional nutrition from the dietitian, she felt less nausea, less heartburn, and better appetite. When she occasionally broke the guidelines, the heartburn and nausea recurred, so she felt that, yes, this is helping me, it's beneficial. She still had some nausea at food smells, but this was less frequent, less intense. She was able to eat meals with the family more regularly and was now feeding her family more nutritionally. With the physical therapy stretching and the progressive muscle relaxation exercises, she could reduce spasticity and related pain except on her worst days. On the worst days, the spasticity, it's medically based and it was just out of control. She was more aware of the onset of any stress-related muscle tension. Because of the increased awareness of her muscles, she now could notice, I'm tightening up, and she was able to start linking it and recognize what she was upset about, what she was responding to. With renewed attention to paced mindful breathing and resonance frequency breathing, this really reinforced her overall sense of mindfulness. Whenever anxiety or worry arose, she would begin to slow her breathing and shift into a mindful state of detached observation of her situation and her mental process. Her ACT helped her to live more mindfully and in a more radical way. She said she had never considered that accepting despair might be positive. And yet, as she focused on observing and accepting despair, the intensity of her distress diminished. And she concluded, realistically I think, that for a 36-year-old woman to live with occasional despair in light of a progressive debilitating illness might be normal and reasonable and maybe even healthy. She shared her mindfulness practices and the Kabat-Zinn book with her spiritual conversations group and taught several of those women to utilize an acceptance mindset in their moments of distress. She reached greater acceptance of the impact of MS on her professional work and reduced her hours, committing to 15 to 20 hours of home office work weekly on financial reports and audits on her own flexible schedules, and stopped going out to companies for audits because that had been so stressful because she never knew which day she might have to reschedule. She shared the mindfulness practices with her spouse, who was her caregiver. He learned several self-regulation skills, including breathing and basic mindfulness, and his moods and stress level were improved even when she had an exacerbation, or what we call a flare. Objective markers